All right, with that being said, I'm going to go ahead and introduce our speaker tonight. We are very fortunate to have Dr. Anastasia Wachter speak to us tonight about the management of complex irritable bowel syndrome. Dr. Wachter went to medical school at the University of Michigan, where she graduated cum laude. Then she completed her residency at the University of Wisconsin. She made the journey out west here for fellowship at Stanford University. She's currently an associate physician diplomat at the University of California, Davis, where she practices general gastroenterology with particular interests in irritable bowel syndrome, chronic constipation, and functional abdominal pain. She's also actively involved in fellow education there. Dr. Wachter, thank you so much for speaking with us tonight, and I will let you take it away.
Okay, thank you guys very much. I'm going to share my screen, and hopefully this is going to work. We were troubleshooting a lot prior, so give me one sec here. Okay, can you guys see that okay?
Perfect.
All right, so I'm going to talk about updates in the management of complex IBS. And fortunately, since I was given this topic, or very shortly prior to being given this topic, we have excellent guidelines that came out, first ever Acg Guidelines for the management of IBS. So I'm going to really focus on, first part of the talk, we'll be talking about those and kind of summarizing their key points, and then we'll get to some cases, and then I'll take your questions. So I don't have any disclosures. And then again, the objectives of the talk today are going to review the first ever 2021 Acg Guideline for Management of IBS. And this was published in January 2021 edition of the Red Journal. And then what I'll do is apply these guideline-based recommendations to aid in the diagnosis and management of patients with IBS. And that's just the reference. And so what we know is, IBS is a chronic, highly prevalent, and often debilitating disorder of what's now being called disorder of gut-brain interaction, or DGBI, formerly known as functional gastrointestinal disorder. So even trying to change the terminology and get away from that, because I know even talking to patients when they say, oh, you have functional abdominal pain, they look at you like, what do you mean? I'm not functioning well. But anyway, so it's obviously within the realm of now what's considered disorder of gut-brain interaction. And what we do know, of course, is that the IBS causes significant health burden with an estimated direct medical cost in the US, excluding prescriptions and over-the-counter medicines, as high as 1.5 to up to, some estimates, up to $10 billion per year. So it's extremely common, expensive, and very relevant. And again, I'm very excited that we have finally a first ever Acg guideline for IBS using the grading of recommendations, assessment, development, and evaluation, or grade methodology, really with the design that was designed to focus on the key diagnostic and therapeutic questions with regards to IBS, with application to everyday clinical practice using treatment options available in North America, as opposed to Europe, where, so that's very applicable to our current practice. And so what this Acg guideline did is they basically came up with 25 position statements assessing 25 clinically relevant questions. And the first 9 position statements were focused on diagnostic testing, because as we know, that ends up eating up a lot of cost in terms of diagnosis of IBS and being clinically confident that the patient has IBS. So we'll talk more about that. And their last 16 statements focus on therapeutics. And through this, they developed 25 position statements and provided the strength of recommendations based on the availability and quality of evidence. And I think what's important with these guidelines is they actually offer suggestions on what not to do in the workup and management of IBS, in addition to what to do. And that becomes, of course, relevant when you have patients insisting on testing after testing, because we'll talk about that, but just because they're not confident or accepting of the diagnosis. And so just to get everyone on the same page, just a quick summary slide in the room for IBS diagnostic criteria. So IBS is defined as recurrent abdominal pain on average at least 1 day per week in the last 3 months associated with 2 or more of the following criteria. So the pain is related to defecation, it's associated with a change in stool frequency and or a change in stool appearance / form. So on this slide, it just describes the Bristol Stool Scale stool consistency for IBS-C, IBS-D, and IBS mixed. And, you know, these are actually, this isn't a talk just about, you know, well, what I'll say is getting, you know, pictures and showing patients these kind of things too, just to kind of help clarify their stool type, even though the Bristol stool chart's not very fancy. It's kind of, you know, some patients find it pretty offensive, but it's actually really helpful. So we know with IBS with constipation, they have Bristol type 1 or 2 stools. IBS with diarrhea have type 5 or 6. And then patients with IBS mixed fluctuate between type 1 and type 6. So you don't get the nice type 3 and type 4 stools that are considered normal. And I do have a different slide summarizing all the IBS, I mean, all the Bristol stool types later on in the talk. And again, IBS is a chronic condition. So the aforementioned criteria have to be present for at least 3 months within the last 6 months, with symptom onset at least 6 months before they're diagnosed, and they have to be present for at least 3 months. And then we all know that the pathophysiology of IBS is multifactorial. There certainly are physiologic predispositions and processes, but the perception of symptoms of IBS are also strongly regulated by central processing. Stress and other psychological comorbidities can exacerbate symptoms of underlying IBS. And, you know, we're still trying to sort out effects of diet, microbiome, dysbiosis, prior gastrointestinal infection as triggers for IBS, and potential underlying gastrointestinal immune dysfunction contributing to visceral hypersensitivity, altered GI motility, and then again, ultimately how it's perceived in terms of severity of symptoms by the patient is a manifestation of disturbed gut-brain axis. And so to get to the meat of the guidelines, so what I'm going to do is just kind of go through the key points for each of these position statements, because I think they're very important. And what's, you know, good now is in the era of evidence-based medicine, of course, is when you can have evidence-based guidelines and even print out, you know, a summary slide of these guidelines for patients. Obviously, also in the era of fake news and misinformation, you know, that people may not believe you, but I find it very helpful, you know, for a lot of patients to provide them with, you know, resources. And this is actually a pretty good resource. It's available on the web and this kind of stuff as well, so that they can kind of, you know, review and just be aware of all the references and everything that kind of went into creation of this clinical guideline. So that's just, you know, for your guys' own sake, is I feel like just, you know, giving patients a lot of information, and, you know, it can be overwhelming information, but nonetheless, it's, you know, evidence-based and it's honest information. So the first position statement that the committee presents is that serologic testing should be performed to rule out celiac disease in patients with IBS and diarrhea symptoms. And this has very strong recommendation with moderate quality of evidence. And this is based on the fact that the overall seroprevalence of celiac disease in North America is 1.4%. And when you actually look at the subgroups of patients with IBS-D diagnosis, there's a 5.7% prevalence of celiac disease. Those with IBS mixed, 3.4%. And even patients with IBS with constipation, there's a higher prevalence of celiac disease than in patients that don't have IBS at all. So I think that's important. So the first 9 position statements are the diagnostic statements. So, you know, what to do in terms of diagnostic, what to do and what not to do. So definitely if you have diarrhea symptoms and other symptoms, you know, consistent with IBS, check a celiac serology as part of the workup and diagnosis. And along those lines, also for statement 2 is that for patients with suspected IBS and diarrhea symptoms, you should check fecal calprotectin or fecal lactoferrin and CRP, even in patients without alarm features, just to rule out IBD. And what they found is that a CRP less than 0.5 entails a less than 1% chance of those patients having IBD. And fecal calprotectin compared to endoscopy has about a 93% sensitivity, 96% specificity at detecting IBD. So if it's normal, it's got, you know, pretty good negative predictive value. So the combination of a normal CRP and normal fecal calprotectin in a patient with suspected IBS with diarrhea pretty much strongly rules out IBD as the underlying cause, and in essence also generally will rule out the need to do colonoscopy. Fecal lactoferrin has a lower sensitivity than fecal calprotectin, but a higher specificity. So I usually just do the fecal calprotectin and the CRP because that's what our lab will run and also obviously get a celiac panel for those patients as well. And then the important thing, and again, what I like about these guidelines is they're telling us what not to do in addition to what to do, is they recommend not performing routine stool testing for enteric pathogens in all IBS patients. We all have a lot of IBS patients who insist they have a parasite, and somebody missed something, and they have no risk factors for parasitic infection. They've never been out of the country, and what the guidelines are telling us is that supporting that fact that you shouldn't just be ordering routine stool testing unless there's a strong indication. And what we know is that a subset of patients that develop IBS do so after an enteric infection, but most patients don't develop IBS after an enteric infection. And those that do occur in about 11% or so of cases, it's female predominance and prior antibiotic use as a risk factors to develop post-infectious IBS. But again, most patients don't develop IBS after an enteric infection. And by definition, when we're diagnosing people with IBS, because they have to have symptoms present for at least 6 months, if they had had a past, viral gastroenteritis or bacterial enterocolitis, it generally would have cleared by the time of diagnosis, as most of those infections are acute. The only exception is giardiasis. There is an increased relative risk of developing IBS after having Giardia infection of 3.4, and we know that Giardia can cause chronic diarrhea, chronic abdominal pain. So testing for giardiasis is indicated in patients with risk factors for that when you're, even though if you're, suspecting IBS, but just to evaluate for underlying giardiasis as potential cause. And so those patients include daycare workers, people that are exposed to untreated water sources, hikers, campers. So not the majority of us, but a subset will qualify to be tested for Giardia, just usually through just stool antigen. And then statement 4, and this is an important one also, is don't perform routine colonoscopy in all patients with suspected IBS who are under 45 unless they have warning signs. So those without warning signs, so no rectal bleeding, no unexplained weight loss, no anemia, they don't need a routine colonoscopy. And the interesting thing about that also is they've done studies and they've shown through this large prospective clinical trial by William Shea in 2010 that they did not identify polyps or cancer more frequently in IBS patients. In fact, they had less polyps and less incidence of colon cancer versus non-IBS patients. And I know a lot of us have been taught that, oh, if a patient has discomfort during a colonoscopy or their colon spasms when we're watching the colon during colonoscopy, that indicates they have IBS. It's not a marker, it's not a diagnostic tool for IBS. So I've even seen on some older reports, oh, patient had, discomfort during colonoscopy indicative of IBS. And I'm like, so we need to stop doing that actually, because it's not a marker of IBS. And then in terms of even working up patients were suspicious with IBS with diarrhea, just keeping in mind that microscopic colitis in and of itself is unlikely in patients under 60. So you don't have to run and do colonoscopies on all these patients. And the most important thing is even a normal colonoscopy does not even reassure these patients with IBS. I mean, you have patients, and I'll talk about my last case scenario at the end of the talk, just who, no matter what you do, they want another colonoscopy and another upper endoscopy and repeat testing when none of it has shown anything, to indicate a diagnosis other than IBS. And that they've actually studied that also, that it does not reassure these patients. So it costs a lot of money, and there's certainly risks with colonoscopy, and it doesn't even help. So that's an important statement. And so along with those lines is position statement number 5, which is a critical change in practice. I mean, I know a lot of us were taught, or we feel compelled that, okay, if we, to label IBS as a diagnosis of exclusion, okay, we couldn't find anything else causing your symptoms, it must be IBS. No, we need to reshape our thinking on this and be aware that, and then so the Acg Guidelines are recommending what we call a positive diagnostic strategy as opposed to this diagnostic strategy of exclusion, meaning that you're going to tell the patient with confidence that based on your clinical presentation, history, labs, etc., you have IBS, as opposed to you might have it, and we need to do some more testing. And what we know is that a thoughtful history, again, a careful physical exam, limited diagnostic testing, and use of the room 4 criteria in and of itself is accurate to diagnose IBS. And extensive testing in these patients is unlikely to discover an alternative diagnosis, in particular if they insist on repeat testing that they've already had. And that's just waste of resources and there's risk for the patients for that as well. So there was a 2013 study of this positive diagnostic strategy that was published in Clinical Gastrointestinal Gastroenterology and Hepatology that showed no cases of cancer, IBD, celiac disease over 1-year course of study in patients that they randomized to the positive diagnostic strategy versus diagnosis of exclusion. And the important thing with this is that earlier diagnosis can lead to earlier treatment as opposed to just waiting to see if they have something else besides IBS. And then unfortunately, we all know that extensive testing in these patients often does not reassure them that there is not an alternative diagnosis, which is unfortunate. But if we start changing our clinical practice and how we're approaching these patients, hopefully their perception of things will change as well. And so not only do we recommend the positive diagnostic strategy to improve in time to initiate therapy, that was statement 5. So statement 6 is we do the same thing, but to improve cost effectiveness. And this has a very strong recommendation with high quality of evidence. We know that 80% of the costs in IBS-D and IBS-C were associated with the diagnosis of exclusion approach. So not even in terms of therapeutics, but just trying to rule out something else. And the key is to use clear and positive diagnostic language, such as you have IBS. That's it. Not it's possible, or I think you need, you have IBS, but we need to do some more testing because I'm not sure. So I think that's a very key takeaway from these guidelines. And again, showing the patient the guidelines, giving them a copy, or you can get the PDF. There's even a couple of summary tables in the article. I think can be very helpful. So the other thing, we have just a few more statements on diagnosis, but for statement 7 is they're recommending that you make an effort to accurately characterize patients with IBS into subtypes, because that helps determine what the most effective therapies for them will be. And then this is a chart of the entire Bristol stool scale. So the 3 and 4 are usually the normal stools that we won't see in patients with IBS. Again, the type 1, type 2 are constipation predominant. Type 5 and 6 are diarrhea predominant IBS. Mixed fluctuates between type 1 to 2 and type 5 to 6. And then type 7 is usually severe. It's usually more the secretory type diarrheas, not necessarily IBS. But so yeah, so it's important so that we can have an accurate subtype. So because the FDA approved treatments that we're going to talk about soon in the next slides were developed with the emphasis based on treatment of specific IBS subtype. The unfortunate thing is there's no currently approved medications for IBS mixed at this time. But when I get to the clinical cases, we'll talk about just clinical approaches to treating those patients in light of the fact that there is no specific FDA-approved medicines for IBS mixed, as you can imagine, obviously, because they fluctuate between constipation and diarrhea, and it's difficult for one specific treatment to treat both of those symptoms. Just 2 more diagnostic position statements. So statement 8, and this is an important one also, is they strongly recommend not testing for food allergies and food sensitivities in all IBS patients unless there are reproducible symptoms concerning for food allergy, because these patients insist they have food allergies, sensitivities, and that they need, IgE panels and all this other kind of stuff, and it doesn't help us, unfortunately. We know that patients with IBS have food intolerances, many food intolerances, but unfortunately there's not great testing to sort out exactly those intolerances, and a lot of it ends up being elimination diets. What we know is that true food allergies are uncommon, only affecting about 1% of the US adult population, and they're more likely in patients that already have atopy. So the classic symptoms of an allergy, despite what patients are going to say when they say I have an allergy, are palate, lip itching, mouth, tongue, lip swelling, or angioedema, rhinorrhea, periorbital edema. Nausea and vomiting can certainly occur in food allergies. It's non-specific. Can occur in other syndromes as well: abdominal pain, diarrhea, dysphagia, urticaria, hypotension, anaphylaxis. And the most culprit foods that cause food allergies are shellfish, peanuts, tree nuts, fish, cow's milk, egg, wheat, and sesame. Again, up to 50% of IBS patients report adverse reactions to food, and up to 20% of the general population report adverse reactions, but these are not allergies. These are just, reactions like pain, bloating, nausea, diarrhea, constipation, but not angioedema, urticaria, or other histamine-related symptoms. And then finally, in terms of diagnosis or diagnostic position statements, this is the last diagnostic position statement, statement 9. And this is interesting too, because they recommend that anorectal physiology testing should be performed in patients with IBS and symptoms suggestive of pelvic floor disorder or refractory constipation not responsive to medical therapy. And what we know, and I was interested to learn when I was going through these guidelines, is that there's a high prevalence, up to 40% of anorectal dysfunction in tertiary care GI centers, and it can be seen in all subtypes of IBS, not just IBS-D. So even IBS-D, when they have this rectal dissatisfaction, straining, even though they're having loose bowel, liquid bowel movements, those patients can also have pelvic floor dysfunction. So unfortunately, symptoms alone aren't predictive of dyssynergic defecation, especially because most patients or many patients with IBS will describe rectal dissatisfaction, the feeling that they still have stool in their rectum despite the fact that they just had a bowel movement. And so accurate diagnosis requires 2 out of 3 tests to be abnormal. And that includes anorectal manometry, balloon expulsion test, or MRI defecography. So if you have that available at your institutions and patients present with those symptoms, it's definitely worthwhile to do rectal physiology testing. And then if it's indicative of pelvic floor dyssynergia, dysfunction, dyssynergic defecation, then get them appropriate therapy. Okay, statement 10. So now we're going to move on actually to the therapeutic recommendations. So there are 16 of these, actually 16 key therapeutic statements from the guidelines. And this is important also because a lot of it, so guidelines aren't necessarily what we do in clinical practice. Some of it is, but when I'll go through this, you'll see, you're like, oh, okay. So statement 10 is they do recommend a limited trial of a low Fodmap diet for patients with IBS that can help to improve global IBS symptoms. And again, global IBS symptoms not only, so that includes the bloating, abdominal pain, nausea, in addition to diarrhea or constipation. So the best study diet that we have in terms of IBS patients is the low Fodmap diet. And it can certainly be used in the short term to see if it helps to improve the symptoms. The key takeaway from low Fodmap is that there are these 3 phases. First phase being just going on low Fodmap, so substituting all foods for low Fodmap choices, then gradually reintroducing these foods while assessing symptoms in response to reintroduction of particular foods, and then having a personalizing their diet to avoid the specific trigger foods in an individual patient. Unfortunately, again, with food intolerances, is there's not some wonderful panel blood test or any other type of testing that we have that can accurately diagnose food intolerances. It's a lot of trial and error, and in part because foods are, complex, made up of complex molecules and, different kinds of polypeptides, fats, proteins, carbohydrates, etc. Unfortunately, we don't know if some patients were to stay on a low Fodmap diet long term, if that affects the gut microbiota negatively, we don't know. And are there risks of micronutrient deficiencies with long-term use that as yet to be seen also. So most of these patients, if they're going to remain on low Fodmap long-term because they feel better, they should be seen by a nutritionist and be monitored for nutritional deficiencies. That's okay. So statement number 7 suggests that trial of soluble but not insoluble fiber should be used to treat global IBS symptoms. So unfortunately, the effect of dietary fiber on the gut microbiome, metabolism, colonic transit time, stool consistency, and bile acid absorption is not completely understood. Soluble fibers are things that can dissolve in water, like psyllium, oat bran, barley, beans, and insoluble fiber are more the root vegetables, whole grains, and wheat bran. And what Moidi et al. In 2014 performed a systematic review of the effect of fiber in patients with IBS and found that the use of soluble fibers, that's psyllium or metamucil, led to statistically significant improvement in IBS symptoms compared with placebo, with no significant adverse effects, but insoluble fiber actually can cause more bloating and discomfort. So it's reasonable for patients with IBS-C to try soluble fiber in the form of something like metamucil or oat bran to see if it helps their symptoms based on that study. And for statement 12, and this is one that, obviously we're all using antispasmodics to treat abdominal pain, and often try to treat the diarrhea in diarrhea predominant IBS, but the ACG actually recommends against the use of the antispasmodics that are currently available in the US to treat global IBS symptoms. This is a conditional recommendation with low quality of evidence, and the recommendation is really based on the fact that there's little data to support the efficacy, despite the fact that these are widely used. And there are a few studies, they're poor quality, small sample size, lack of standardized enrollment criteria, and they're decades old. So should somebody want to do a study now and test everything in a randomized control fashion, I think that'd be very helpful. But based on the available data, the ACG panel is recommending against the use of antispasmodics in favor of other treatments that have better evidence, which I'll go into in just a sec. Including, okay, so they do recommend the use of peppermint to provide relief of global IBS symptoms, including abdominal pain, because we know that peppermint oil has a relaxing effect on smooth muscles. So that is based on a 2019 meta-analysis of 12 randomized controlled trials, with a total of 835 patients, with number needed to treat of only 3 for improvement in overall symptoms and 4 for improvement in abdominal pain. So that's a pretty low number to treat. We know that there are commercially available peppermint oil supplements over the counter that are available. IB Guard is one of them that contains peppermint oil. FD Guard contains other things besides peppermint oil. But so that is recommended in terms of to try to provide relief of symptoms based on the evidence that they have, but definitely further trials are needed. And I don't know if anybody's going to embark on an actual randomized controlled trial of antispasmodics in IBS, because I don't know if there's the financial incentive to do so, but I think that would be very helpful just to know, because we do use those very routinely in clinical practice. And then statement 14, and this is another recommendation, based on the evidence available, is that they suggest against use of probiotics for treatment of global IBS symptoms, despite the fact that there is widespread use of probiotics in the US, amounting to $6 to $7 billion of cost per year. We all know that, that's the first question I get from many patients is, what probiotic do you recommend? What probiotic should I be on? And I'm like, I don't routinely recommend any probiotics until there's better data. But so what we do know is that enthusiasm for probiotics has certainly outpaced the data supporting their use. There was a 2018 meta-analysis of 37 trials showing that combination probiotics had better efficacy than single species. But unfortunately, as with most studies of probiotics, especially when you're trying to compare them in a meta-analysis fashion, there's significant heterogeneity and publication bias, and we definitely need better randomized controlled studies of probiotics to know whether or not they're helpful. But at the moment, for right now, based on the current evidence that is available, ACG recommends against use of us as providers recommending probiotics for management of global IBS symptoms. The patients will do their own thing. The probiotics are not FDA regulated, and so they'll do what they're going to want to do anyway. But at least from a evidence-based standpoint, we should not be routinely recommending them. Oh, sorry, I forgot I had one more slide on this. So yeah, so the summary is, again, it's certainly an important area of research given the role of intestinal microbiota that in IBS, which we're still trying to delineate. We don't know exactly how the intestinal microbiota directly causes symptoms of IBS or other gastrointestinal symptoms. And again, existing literature is problematic. Future trials are needed. Still have a lot to learn along that line. And then so statement 15, we're almost done with the statements, we're getting there. So the ACG suggests against the use of PEG products like Miralax, Glycolax to relieve global IBS symptoms in patients with IBS-C. And I know a lot of us just kind of reflexively will try, especially for IBS-C patients, we'll try Metamucil. If that's not helpful, we'll go to Miralax or another PEG product. And unfortunately, the 2 trials of use of PEG products for IBS-C have shown improvement in constipation, but not in abdominal pain or overall symptoms. And unlike trials in chronic idiopathic constipation that have which again, their endpoint is just management of constipation. So it's very effective for management of chronic constipation, but when you throw in abdominal pain, bloating, the other IBS symptoms in the mix, it doesn't help the global symptoms. And I think it's important to remember that they recommend against use of it for global symptom relief. You can certainly try it for first-line treatment in IBS-C given its low cost and availability, but just knowing that there are other options available that have better efficacy to treat the global symptoms, including, pain. And so this is where we get to our secretagogues. So the chloride channel activators, and then we'll talk about the guanolate cyclase activators. So lubiprostone is the one chloride channel activator that we have, and there is strong recommendation and a moderate quality of evidence to recommend it for treatment of IBS with constipation. So it's a prostaglandin E1 analog. It binds to type 2 chloride channels in the GI tract, causes increased secretion, and it's approved, FDA approved to treat women with IBS-C at a dose of 8 micrograms twice daily. The 24 microgram twice daily dose is what's approved to treat idiopathic constipation. Certainly, you can try the higher dose if the lower dose is ineffective, but according to the current data and FDA approval and the guidelines, the initial dose to try in these patients would be 8 micrograms twice a day. And this is based on 3 randomized controlled trials and 1 high quality systematic review showing that global IBS symptoms improve with use of lubiprostone as compared to placebo. About 11% will develop nausea as one of the major side effects. Of course, diarrhea is also a common side effect, but the nausea itself can improve by taking this with food, and then it typically will resolve over time. And then along those lines, the ACG panel also recommends the use of guanolate cyclase activators to treat global IBS symptoms. And these medications, so we have 2 available currently, linaclotide and plecanatide. So they target receptors on apical membranes of the intestinal epithelial cells. They stimulate fluid secretion and peristalsis. And linaclotide, the dose for IBS-C is 290 micrograms daily. And based on 3 large phase 2b/3 trials, the number needed to treat is only 6 to get symptomatic improvement. So that's pretty good. And plecanatide has a higher number to treat of 9, but the dose is 3 milligrams per day and definitely worth recommended to try to treat global IBS symptoms, abdominal pain, constipation, bloating, etc. And still sticking along with IBS-C. So the 5-HT4 agonist Tegacerad is available to treat IBS symptoms under specific provisions. Initially, it was approved in 2002, but then what happened is they found that there were some increased cardiovascular adverse effects in these patients. So that led to the recommendation that you can, it is available now without, you don't need a special permission from the FDA, but you can get it, and it's approved to treat IBS symptoms in women only, not in men, under 65 who have 1 or less cardiovascular risk factors who have not adequately responded to the secretagogues, which is the lubiprostone, Linzess, plecanatide. So that is an option, and enough so where it can be helpful that it's included in these guidelines. So serotonin, we know, is a vital neurotransmitter that modulates GI motor and sensory function. And then when you stimulate the 5-HT4 or serotonin receptors, you get it stimulates peristalsis, accelerates GI transit, and that's which initially led to its approval in 2002, and subsequently, what happened was it was voluntarily withdrawn from the market in 2007 over concerns for a small number of cardiovascular events. And so what happened then is there have been since then, they've done 2 separate external adjudications of the large clinical trial database in patients with IBS-C and dyspepsia to really determine what is the magnitude of cardiovascular risks associated with Tegacerad. And based on that, they found that patients over 65 with at least 1 cardiovascular risk factor were more likely to have cardiovascular events. So then they said, okay, well, we can reapprove. It was reapproved in 2019 for women only under 65 with one or less cardiovascular risk factors. So it's an option. It's not first-line therapy by any means, but if you have patients with refractory IBS-C where other things haven't helped, women under 65, one or no cardiovascular risk factors, you can certainly try it at a dose of 6 twice a day. Okay, almost done with the statement. So statement 19, ACG does not recommend use of bioacid sequestrants to treat global IBS symptoms. We know that 10 to 30% of patients with IBS-D do have bile acid diarrhea, but unfortunately there's very limited data, including two very small studies in patients with IBS-D, and it's unclear. Well, it can help the diarrhea, but the bile acid binding agents have not been at this point shown to help other symptoms like bloating, abdominal pain. But again, these are super small studies, 27 patients, 12 patients. So bottom line with use of bile acid sequestrants in management of IBS-D is we just need some better data. Now, where we do have moderate level, good data, strong recommendation is for Rifaximin that can be used to treat global IBS-D symptoms. And I'm sure a lot of you have already used this in the past. So Rifaximin is a non-absorbable antibiotic used to treat IBS based on hypothesis that a portion of patients with IBS-D have abnormal microbiome, and it's supported by 2 large randomized controlled trials, Target 1 and Target 2, that showed increased improvement in abdominal pain 1 month after the 14-day course. And Target 3 was a retreatment trial showing you could use a second course in patients who relapsed. The nice thing with Rifaximin, also it has very favorable safety profile. And what we do know is that patients who do happen to have a hydrogen breath test prior to starting Rifaximin, those that have a positive breath test have a higher likelihood of responding than those who do not. If you do that, you don't have to get a breath test in patients, with IBS-D in order to prescribe Rifaximin. The downside, of course, is that the cost. There's no generic equivalent available in the US. And so a lot of insurances will not, they'll cover it for IBS-D, but only after you've failed other therapies. So it won't be covered as first-line therapy for IBS-D. Statement 21, the ACG recommends the use of Elocitron, which is an older medication that was initially approved in 2000 and then withdrawn several months later because there was increased rates of ischemic colitis in these patients, but it was reintroduced in 2002 for patients only for women with severe IBS-D who failed traditional therapy. So I won't spend too much more time on it because we're like running out of time. But basically it's an option for patients who fail other therapies. Now, along those lines, there's another mixed opioid agonist antagonist that can be used to treat global IBS-D symptoms called Alexadeline, which is known commercially as Ibsc. And it is approved, again, to treat men and women with IBS-D at a dose of 100 milligrams twice daily, but there's a 75 milligram twice daily dose as well. And so the ACG suggests, consideration of that to treat IBS-D symptoms based on, 29 response rate versus 20%, 19.5 response rate for placebo with a number needed to treat of 10. It's also expensive, and but it's another option available for refractory IBS-D symptoms. However, the thing with Alexadeline is you have to remember that it's contraindicated in anybody who's had cholecystectomy, sphincter of Oddi dysfunction, known or suspected biliary obstruction, history of pancreatitis, drinks alcoholic beverages, greater than 3 alcoholic beverages per day, or any structural disease of the pancreas. So a lot of our patients are not even candidates for this, but it's just something to keep in mind for refractory IBS-D. Now, the one thing that is been around forever, cheap, covered by insurance are the tricyclic agents. And the ACG does recommend using tricyclic agents to treat global symptoms of IBS. And they are probably underutilized in this case. But this includes amitriptyline, nortriptyline, imipramine, and dazipramine. And there's strong evidence supporting their use in somatic neuropathic conditions such as diabetic neuropathy, fibromyalgia, and headaches. And they improve pain in IBS due to anticholinergic effects, and at higher doses can improve diarrhea in some patients. But you can use TCAs to treat global symptoms of IBS, patients with IBS-C and IBS-D. you don't have to shy away from, of course, if they were to cause worsening constipation, you can stop, but ACG does recommend TCAs be used to treat global symptoms of IBS. And I'm just going to I'm skipping a little bit because we're running low on time. So statement 24, and this is another thing underutilized for management of IBS. Gut-directed psychotherapies can be used to treat global symptoms of IBS. There's good evidence to support their use. And as you can imagine, because IBS is a disorder of gut-brain interaction, that focusing on reordering, I guess, the disorder of gut-brain interaction can actually help. And that skill-based techniques, including relaxation training, cognitive reframing, other techniques can alter pain perception and help increase psychological flexibility in these patients. The main thing limiting this is just availability of care providers and also cost. And the last statement is that, and this is an important one also, is that they recommend against the use of fecal transplant for treatment of global IBS symptoms. I know obviously fecal transplant can be used to treat refractory C. difficile, but thus far it has not been shown effective for treatment of global IBS symptoms. Okay, and so I think I spent way too much time on those, but I just really wanted to go through all that stuff with you guys because I think it's really important that those position statements are out there and that you can certainly apply them to patients with IBS. You should apply them, an evidence-based approach to these patients. I'm going to get to the cases. And so the first clinical scenario we're going to do, and the cases are actually pretty short, but is a patient with IBSD. And we've all seen this kind of typical patient, 45-year-old female with migraine headaches, depression, prior diagnosis of IBSD, presents to GI for further evaluation and management. And her symptoms are typical severe crampy lower quadrant abdominal pain, occurs when she first wakes up in the morning, as well as after meals and often accompanied by fecal urgency. She then proceeds to pass several loose Bristol type 5-6 non-bloody bowel movements and has relief of abdominal pain, but will have constant sensation of bloating despite passage of bowel movements, which is worse after eating. She has no alarm symptoms, no family history of GI malignancy or IBD. And so she's currently on sertraline for depression, sumatriptan and ibuprofen as needed for migraine headaches, and loperamide, which helps her diarrhea, but does not help her pain or bloating. And so when you see her, she has some labs that are CBC, CMP, TSH, celiac panel and normal, but she hadn't had prior CRP or fecal calprotectin, although she had a colonoscopy years ago, which was normal. And she's tried gluten-free diet, lactose-free diet, low Fodmap diet, no improvement. She tried many over-the-counter probiotics with no improvement. And so in this case, what I wanted to just kind of highlight, and I apologize because we're going fast, is, in this particular patient who's had a lot, some work of what additional diagnostic testing may be helpful in her case. And I think because this is supposed to be more of a, kind of complex IBD, is in this particular patient who's on an SSRI, who's having IBSD, and if she has worsening symptoms, you can certainly consider a colonoscopy to look for microscopic colitis. She's also 45, so she's kind of due anyway for screening purposes. And in those patients, you can certainly offer them colonoscopy for that, as well as to get random biopsies to look for microscopic colitis, as that could certainly change her management. This patient also, if you're thinking about diagnostic studies, you can certainly consider a hydrogen breath test, or since she hasn't responded to other therapies for IBSD, you can just try a course of Rifaximin, a 14-day course. It's FDA approved, and see if that helps. Some patients want the breath test, not everybody. Some patients are very willing to just go with the 14-day course of Rifaximin and see if it helps them. And in this case, with this patient, she wanted to do a colonoscopy. Well, we did a colonoscopy because she was 45, but she wanted another one anyway. There was no evidence of microscopic colitis or polyps. She did a 14-day course of Rifaximin, which really didn't help, unfortunately. So then you're kind of left with, okay, what do we do next? And again, based on the guidelines that we have, you can certainly consider weaning off of sertraline and starting a low-dose TCA, because the sertraline itself can sometimes exacerbate diarrhea. She also has migraine headaches, so that could be advantageous to treat her migraine headaches as a prophylactic agent, may improve, her depression as well. And this patient, her depression was well controlled on sertraline. She did not want to stop the SSRI because she was getting so much benefit. So in this case, you're said, okay, well, TCA is not an option for you. So other options based on the Acg guidelines is you can certainly use peppermint to help for global relief of symptoms. He does qualify as a patient who can be considered for a low citron and Alexadeline as well, because she hasn't had any cholecystectomy or pancreatic issues or alcohol. So those are things to consider for refractory cases. And then of course, I just want to emphasize too that just the gut-directed psychotherapies can help treat global IBS symptoms. And ultimately, this patient chose a trial of Alexadeline. She had no contraindications and she improved, but she's looking into financial feasibility of gut-directed psychotherapies. So what I'm wondering, so it's 6:52. I will do the Ibsc, this one real quickly, and then maybe we can kind of stop for questions. And I sincerely apologize. I thought we'd have more time. It's taking a long time. So the Ibsc clinical scenario, one of my patients, so I have a 35-year-old with hypothyroidism, but she has a normal TSH on hormone replacement, but even starting hormone replacement did not improve her constipation. She also has bloating, intermittent nausea, left-sided pain, worse in the morning, worse with stress. So pretty consistent history with Ibsc. She did have a colonoscopy at 33 because she was having intermittent minimal bright red blood per rectum, but at that time had a small anal fissure and internal hemorrhoids, but no evidence of malignancy or IBD. So she has no other alarm symptoms other than the previous minimal bright red blood per rectum. And she's tried high fiber diet, including both soluble and insoluble fiber, which caused her increased gas and bloating. She tried psyllium, somewhat helpful, increased her bowel frequency, but did not help her pain. She also tried polyethylene glycol, improved bowel frequency, but again, no change in pain. On her own, she tried probiotics, which were not helpful. Well, excuse me, were minimally helpful. And she also did try dicyclamine, which was helpful for abdominal pain, but certainly did not improve her constipation. And so just going back to the clinical statements or how we would use those to recommend further treatment for Ibsc. So you could offer her a soluble fiber trial in the form of psyllium rather than just the high fiber diet she kind of did on her own. That's a possibility. We know again for statement 15 it suggests against use of PEG products, which was consistent. I mean, she didn't have complete relief of global symptoms. I'm just highlighting this that they again recommend against use of antispasmodics, against probiotics, but a lot of these patients will have been on it before you see them. And then the next step, of course, is then to offer her a trial of secretagogue. So there's 3 that are approved for Ibsc: lubiprostone, linaclotide, or plecanatide. And generally, I'll go over the risks, of each. And then ultimately, it's a patient's decision, but also depends upon what insurance will cover. So in her case, insurance covered lubiprostone, the lowest tier. So she tried it, she got nauseous, and then she took it with food also, but the nausea did not abate. So then she tried linaclotide. She got a mild headache, which resolved over time. And she did have improvement in bowel frequency and consistency and abdominal pain and bloating, but still had straining. And I think, in these patients, this is where with the guidelines talking about, okay, if they're still having symptoms of defecation disorder, despite improved treatment in bowel frequency and consistency, you should order anorectal physiology testing. And she ended up having anorectal manometry, showed dyssynergic defecation, and is currently undergoing pelvic floor biofeedback. So the take home of this scenario is to just consider getting anorectal testing for patients with Ibsc, also with IBSD, when they have defecation dysfunction that does not improve with other therapies. And again, other therapies to consider: low Fodmap diet, peppermint oil, gut-directed psychotherapy, and then Tegacerad. She would qualify for Tegacerad because she's under 65 and has less than 1. She has no cardiovascular risk factors, actually. And so I'll probably, just in the interest of time, sorry. I mean, I can go on. I have no problem if you guys are willing, but if you want me to stop, I have probably maybe 10 more slides, but I can certainly stop and take questions. So what do you want to do, Liat? You want me to finish or, sorry?
I think we probably should wrap it up.
That's what I figured, yeah.
Just in the interest of time.
Yeah, let me do this. Let me just do the last, sorry. Just a quick summary, just the principles of management. And I think
Perfect.
the guidelines are there. I encourage all of you guys to read through them. I mean, the goals obviously are to exclude organic disease, which we can usually do just by physical exams, some simple labs, and clinical history. Make a positive diagnosis, establish good rapport, categorize IBS based on prevalent stool form, first-line therapy, lifestyle dietary modifications, and then escalate quickly to the FDA-approved validated therapies. And again, avoid routine stool testing in these patients, even when they insist they have a parasite. Avoid routine colonoscopy, again, in young patients without warning signs. Avoid routine testing for food allergies, routine long-term use of antispasmodics, routine use of probiotics and PEG products. Okay.
Thank you so much, Dr. Wachter. That was fantastic. We have a couple questions in the chat that I'll just pose out in the last couple minutes. So someone asked, is there a situation in which you would prefer fecal lactoferrin over fecal calprotectin?
I mean, I think one or the other. I don't think there's one, I usually end up just ordering the fecal calprotectin because that's what's fun at our institution. It comes back a little quicker. And I mean, they're, if you're doing a CRP plus a fecal calpro or a fecal lactoferrin and they're both normal, I mean, you have pretty good, let's say if the CRP was elevated or the fecal calpro, I mean, I don't, there's still very, there's still very good sensitivity and specificity, over 90% for both. So I don't have a preference per se. I'll just pick the calpro I think has actually been, if I'm not mistaken, it's been better studied. Let me just, I have it in here. I think the ACG kind of favors the calpro. Yeah, they have a strong recommendation for fecal calprotectin with moderate quality of evidence, and then they have low quality of evidence for the fecal lactoferrin. So I guess I would go with the calprotectin just based on the ACG's evidence-based.
Awesome. All right, and then someone else is asking, can you comment on whether your practice is to avoid the use of PEG and IBSD? Are cheap generic medications at a disadvantage in the grade method when going up against new commercially funded and higher powered trials?
Oh, definitely. Yeah, I mean, I think with a lot of these, I mean, these are, it's always great to have evidence-based recommendations, but we're not going to have evidence-based recommendations for every scenario, unfortunately. And again, likely a lot for that reason, because I mean, are you going to have Miralax sponsoring a trial? Well, actually, I shouldn't say that. No, PEG products they've been evaluated in terms of in randomized trial, but in terms of like the antispasmodics, in terms of some other things where they don't have, I mean, there's not the desire from the company to kind of run these randomized clinical trials. I mean, I think it's always nice to have the guidelines, and I obviously this is supposed to be an evidence-based talk, so I'm very glad we have these, but we're all physicians and you also have to make decisions based on your specific patient, cost, other kind of things. Do I try PEG products and psyllium and IBS-C patients? Yes, all the time, because again, for that reason, they're cheap, they're easily accessible. And if, it doesn't take long to really, whether they're gonna work or not. And I mean, we all see also different gradations, different patients with IBS with different severities. I have some people with mild symptoms and, they can respond easily, much better sometimes to some of these like simple regimens. And then patients with very severe symptoms, often do not. So I think it's important to realize what's out there to try, and certainly try the evidence-based things, but then also if they're not successful or if they're not, accessible because they have a huge copayment or things like that. I mean, yeah, you can certainly fall back and try the other things. I mean, the one nice thing with the peppermint oil having evidence for efficacy and also being available over the counter, I think that's been nice. I've had a lot of patients, using IB Guard, and it definitely helps. And the nice thing with that is it also doesn't cause some of the neurologic symptoms that the antispasmodics can, but it can cause heartburn, but it's not going to cause confusion or, drowsiness or especially for older patients where you kind of worry about the anticholinergic side effects of the, hyoscyamine and Medicare. Actually, a lot of my Medicare patients, like they won't cover hyoscyamine or dicyclamine anymore. For patients over 65, they say, no, they're not indicated. So I have patients that were on it before and then they pay out of pocket. But they are helpful. I mean, they're definitely helpful. I know anecdotally, they're helpful for patients. And so like, I wanted to present these guidelines, but just kind of keeping in mind, okay, what do we actually do? And, do I think there's going to be this great RCT of, hyoscyamine versus, Linzess or something like that? No, probably unlikely. I think it's just I think the important thing is just to have a lot of tools in our toolbox and things we can try and, and hopefully help. And the key takeaway from this talk too is just to, obviously establish, a confident diagnosis, be open with patients about what's available, and I always tell them too, I said, it might not be, in the guidelines, but we can certainly try it. And then, you kind of have a discussion with the patient and what they want to try based on what's, what's out there, what's available.
Thank you so much, Dr. Wachter. It's right after 7, so I think we should probably wrap up, but we really appreciate you taking the time to present tonight. This was super high yield and helpful to all of us.
Thank you, guys.
Thank you so much again.
Rest of your evening. Okay. Bye-bye.
Take care.
Thank you.